We will be live in 5, 4, 3, 2, 1. Good evening, everyone. We welcome you all to OrthoTV online in association with UPOA. To introduce today's topic and speaker, I hand over to Dr. Ashutosh Agrawal.
Good evening, everybody. We are having in the series of UPOA Arthroscopy webinar. The theme is shoulder. Now today we have three learned speakers: Dr. Dhananjay Gupta from New Delhi, Dr. Rajiv Gupta from Jaipur, and Dr. Pradip Nemade from Mumbai. We have three panelists: Dr. Swarup from Meerut, Dr. Prasoon Shamshery from Lucknow, and Dr. Imran Akhtar from Gorakhpur. The speaker moderated by me and Dr. Vinay Panday. He is from Varanasi. Now I request Dr. Anup Agrawal sir to say a few words.
Thank you, Ashutosh, and welcome everyone on the panel and the speaker. Today we have an very experienced faculty over here who will be discussing about the shoulder arthroscopy, and that's the main purpose of doing these Friday webinars is to learn delegates about the intricacies of the subject which we are conducting, and every fourth Friday we are doing an arthroscopy webinar. So let me take this opportunity to thank Varanasi Orthopedic Club and especially Dr. Ashutosh for taking all the pains to do all this. So thank you all the faculty, panelists, Varanasi Orthopedic Association for doing this wonderful program. And thank you Neeraj from OrthoTV for doing us this favor of conducting this on OrthoTV. Thank you everyone. Thank you Ashutosh.
Dr. Ashish, you are here?
I'm here. Very much here. Hello.
Sir.
Ashutosh.
Sir, कुछ बोलेंगे?
So, Anup has said the same thing.
Okay,
Nothing
sir.
is left over. You just begin with the program. There's no sense of doing all these things so
Sir,
long.
Sir, I request all the speakers to check on the time and all the listeners to keep themselves muted. We'll have discussion in the end and keep all the questions in the chat box. Now, the first speaker is Dr. Dhananjay Gupta. He's the Director, Department of Orthopedic Surgery, Fortis Hospital, Vasant Kunj, Delhi. He's the Founder Director, Dr. Joint's Clinic, which is practiced all over India and abroad. His special interest in sports injury, bone preservation, reconstruction, and replacement surgeries. He has various national and international presentations as merit. He has authored a book on Prasoon femoral fractures. He will talk on first time Dislocator, how to proceed. Dr. Dhananjay Gupta.
अपने हिसाब से तो कोडिंग बनवाते हैं।
Hello friends.
कहाँ लगनी है कहाँ नहीं लगनी है।
Actually, all of you, kindly mute yourself.
Am I audible? Can I start?
Yes, sir. Sir, you are audible.
Well, first of all, I would like to extend my thanks to U.P.Orthopaedic Association, Dr. Ashish Kumar, Dr. Anup Agrawal, and of course Ashutosh Agrawal. Dr. Goyal is also there. I saw him there on the screen. It's always a pleasure to be associated with such activities, especially Varanasi and UP. And when we were discussing about this Friday musings, we thought, let's give them a thought, rather they can muse over it and decide, because shoulder dislocation is one such emergency which an orthopedic resident gets in the emergency. And we just leave it at that. We don't pursue it further. But somehow the things have changed tremendously from the days, from the times where we were the residents, and one reduction means that's it, the patient goes back home. Dr. Mohit, I would like to thank him, my associate here. He has been instrumental in helping me out with this talk. So let's say, first time shoulder dislocator, how to proceed in such situations, in such circumstances. There's a problem, I can't scroll down, I guess. Okay. So, as we know that not all shoulder instability cases, they are the same. There are a lot of variations One can be anterior dislocation, one can be posterior dislocation, inferior dislocation, and some can present with the fracture dislocation. And some of the patients, they do present with multi-directional instability as well. So there's a whole spectrum of the situation you encounter with. Some dislocated patients, they come with the impacted head also with the fracture, making it difficult to reduce. We all know about the anatomy. This is just like a golf ball on the tee. You have head of humerus here and a very narrow support, which is enlarged with the help of the soft tissue structures such as labrum, capsule, ligaments, rotator cuff, deltoid, and the pectoral muscles. And this is how it gets its wonderful mobility at the cost of the stability. We're not going to go into much of details pertaining to anatomy. We all have gone through it. So the next comes is the patient evaluation, which is of course the most important component, most important part. Even if you see that there is a fine curve dislocation still, you like to document each and everything. Apart from doing your routine ABC, the physical examination where you see the attitude, the strength, amount of muscle atrophy, that gives you the guidelines whether the patient has been having a recurrent episodes or not. Motor and sensory examinations absolutely mandatory along with the vascular examination. Most of the acute episodes you are going to find very painful reflection of the movements, but nonetheless it should be there. And you perform the spatial test to assess whether it's really lax or it's a very tight dislocated shoulder. Next comes your imaging. Again, something which you cannot really miss. Apart from the AP, you need to get an actually lateral view to confirm whether there is posterior or anterior dislocation. CT is something which you need to do after the reduction which has been reduced to assess the bone stock. If you find that the X-ray is showing some bony fractures, some shadow, which is quite doubtful, you should get it done. MRI is usually reserved in the young cases where you are contemplating intervention earlier than expected. It can be done with or without arthrogram. The basic idea is to evaluate the soft tissue structures around the shoulder joint, which would have been damaged, and gives you the idea if you plan to go for the surgery. Well, the shoulder instability or the dislocation can be traumatic versus atraumatic. The direction of instability is important because this is going to decide your future course of action. The age is very crucial because it tells you how aggressive you are going to be in the treatment of this particular pathology. Single episode versus recurrent, yes, because again, this is going to have a bearing on your planning, how you're going to take up this issue, whether the arm is dominant or non-dominant, what are the activities patient is engaging in, whether is he a sportsman, is this use of the arm going to be very crucial for him, is it the middle of the season, he needs to go back to the action, and other comorbidities, etc. Well, it was a study which was so-called Moon Shoulder Instability Study, which came out in 2018, and they said that out of they did the study of almost 700 shoulder dislocations, and almost 700 dislocation shoulders, and they said that the mean age was almost 24 years. 82% patients were males, and the primary direction of the instability was 74% interior for males, 73% for the females, and most of them, they sustained this injury while playing the football, especially football. 24% incidence is quite high, and the basketball 13%. Another cause behind the dislocation could be ligamentous laxity, but they were able to come out. I mean, they were able to get this fact from the study that most of them were post-traumatic dislocation. So as we all know about the anterior dislocation, the attitude is typical, abducted, and externally rotated. The recurrent dislocation is usually seen in the younger age group, and the incidence decreases as the age increases. And as we discussed earlier, the incidence is much higher in the males, and also if they're involved in the contact sports. The associated injuries with rotator cuff tears is very uncommon in the younger age group. Usually it is seen in the higher age group above 40 years of age, and they are associated with 40% rotator cuff tears. The initial management, as we all know, consists of reduction and immobilization. The associated lesions, when we are talking about the soft tissue lesion, that is the Bankart lesion, so it can present itself in the form of simple avulsion of inferior glenohumeral ligament from the glenoid, which is the most common pathology which happens more than 90% of the cases, and at times there could be bony component at times. Then there can be reverse injury. Instead of the labrum getting peeled off from the glenoid, is the humeral avulsion of the glenohumeral ligament, which is called HAGL, which happens in less than 10% of the cases. So as we discussed earlier, that the close reduction under the least traumatic conditions is the ideal thing. It should not be stress to the patient and the surgeon also. If the need be, you can give anesthesia and see to it that it is an as a traumatic experience for the patient as well as for the surgeon. And there comes the issue of immobilization. How do you like to immobilize? There were a lot of studies, rather theories, which said that if you immobilize it in external rotation, your recurrence rate is decreased. But beyond that, immobilization position is not important at all. There was a level 1 study that it hardly matters. So post-reduction protocol is something which varies from patient to patient, patient to situation. It's about 1 to 3 weeks. In the elderly citizens, in the senior citizens, you don't like to immobilize them and allow them early mobilization so that they can regain their functional range of movement. In the younger age group, just to be on the safer side, you like to stick to a long period of immobilization. Whether it helps or not.
Can someone tell them to stop noise, because there is additional noise on Dr. Anil Gulia and Ramit Dhalla?
Dr. Anil, kindly mute yourself.
I think the admin can do it on its own.
Host can mute. No, who is the host?
Dr. Anup, Anup sir.
Okay, I think
I would like to proceed.
Yeah.
Yes, sir. Sir, proceed, sir.
Sure. So after this immobilization period, the patient is put on physio rehab. How much useful it is to prevent the recurrence, we don't know. But definitely it makes sense to regain the muscle strength and the stamina so that the patient can continue with their life. There's a very interesting paper which came back in 2004, which suggests that the athletes, the high demand athletes, when they were in the middle of the season, they had an acute episode which was reduced, and almost 87% of them were able to return to the season and played well. But the chances of recurrent dislocation was almost 1.5 times higher, and more than 50% of the patients had to go for the surgery in the following off season. So that means we are looking at a situation where my success rate If after that primary episode is only 50%, whether I immobilize or whether I rehabilitate.
ये लगाना है
वो नहीं लगेगा
So that means
कुछ नहीं तो कई है जो कैल्शियम कैल्सिटोल या ऐसे ही लिखा जाता है
there are certain issues which goes beyond the conventional thought process that you immobilize for sufficient time and the recurrence can be prevented. So a study recently published, they talk about the athletes with the anterior shoulder instability. How do they perceive the injury and how do they see the treatment? Well, it was again almost 45 patients. 30% of the patients opted for the early surgery. I mean, the reason why we are discussing all these talks is that my perception could be different, the patient's perception could be different. So this is the patient's perception, who is a high demand individual who needs to go back to his active sports, which is a source of his income and living. So 30% of the patients, the athletes opted for the early surgery, 9% at the end of the season, and 62% opted for a rehab plan with a wait and watch approach. Out of this 62%, 50% had to undergo surgery subsequently. So my dear friends, this is becoming quite clear that yes, you have to think in terms of perhaps intervention even after the first episode. But then the perception that what was the influencing factor of the athletes, why they went to give up, what exactly options they had and how they took that particular decision. So it was influenced by, number one, his willingness to give up sports, that fine, enough is enough. I had this particular episode. For me, the sports career is over and that's it. All those people, those who had more than one dislocation, they understood the futility of the conservative treatment. Then the timing of the season, whether it is a mid-season, off-season, that was important in their decision-making and the recruitment prospects. That if they continue playing, they'll be picked up further and then perhaps in the off-season, they can go for the surgery. And the most important one was the doctor's influence. How seriously, sincerely, the doctors sat down and explained to them about the pathology, about the causes, and what's in the future for them. It was again which helped them in coming to their decision whether to go for the early surgery or not. So there was a systematic review which was done, rehabilitation versus operative stabilization for the treatment of first-time anterior shoulder dislocations. And this is another recent study where they did a review of the various studies earlier done to find out the ideal protocol which can be prepared to advise the patients and the doctors how to proceed further. So they saw to it that all the studies, they have either level 1 or 2 evidence available, and they took the help of the PubMed, the PubMed database, systemic reviews, etc. So they concluded that supports operative treatment is a reasonable alternative to non-operative primary acute shoulder dislocations in the young adults participating in highly demanding physical activities. So this was number one. Number two, recommendations on the optimum surgical intervention cannot be provided because it varies from the pathology to pathology. What type of lesion are you looking at? Whether it is soft tissue or the bony? I'm pretty sure our next speaker, Dr. Rajiv, will elaborate on that. That's his topic. So that means there is a substantial risk if you don't intervene after the first episode. That means that if you continue with the non-operative management in the young male athletes, there are high chances of recurrent instability, damage to the joint, or the glenoid over time, necessitating open procedure. There's a reported correlation with number of dislocations and risk of failing surgical management. And of course, joint arthritis with the repeated episodes. So the optimal treatment strategy, it varies from case to case. There are certain patient-specific factors and then injury-specific factors which should guide you in making your plan whether to go for operative or to give a trial of conservative. So number one is the age. As we all know, younger the patients, higher the chances of recurrence subsequently. Activity of the sport, higher the activity level, more is the requirement and the demand, and we should intervene early in the status. The working status of the patients, then goals. What exactly are the objectives or the goals of the person, of the patient, and how many number of episodes that patient had. So these are the patient-specific factors. And the injury-specific factors, acuity of the injury, how severe the injury was, were there any associated fractures, and then of course the degree of bone loss. So the acuity and the degree of bone loss, these are the injury-specific factors which should help you in making up your mind how to proceed further after the first dislocation. So as we all know, the risk factors for recurrent instability are number of events, age at the first episode, contact sports, overhead athletes, ligamentous laxity, and concomitant bony pathologies. We all know about other factor is the bony pathologies, which have been somehow deciding the ultimate outcome even after the soft tissue surgeries, because they have a very big role to play. So Bankart et al., he evaluated his own series, 194 consecutive arthroscopic Bankart surgeries, that's a soft tissue surgeries, and he found that the recurrence rate was only 4% in those patients where there was no significant bony lesion. While those cases where there was a bony defect, either in humeral head or in the glenoid lesion, there was 60% incidence of recurrence, which is quite high. It's as good as we should not be doing it. So we know now there are going to be glenoid defects, which are so-called bony Bankart lesions, and the incidence is quite high. I mean, it's not something which you can take it for lightly. You find almost 22 to 41% incidence in the first timers, which can go up to 86% in the recurrent events. Most of the time, it is the anterior-inferior rim of the glenoid with the labrum, which gets detached, which gets broken up. As we all know, the glenoid cavity has a pear shaping. Here, if there is a big lesion, the big chunk, which is of the bony area, which is gone off from the anterior rim of the glenoid, your pear becomes inverted, making it highly, highly unstable. Pigliani came up with the classification further. He said that type 1 is the one where it is non-displaced anterior glenoid fragment. Type 2, again, it's a small anterior fragment which is detached from the labrum. If you look at the image, you'll find that the bony chip is still attached with the labrum. So that's why it's type 1. If it gets detached, I mean, in the image, it is attached. If it gets detached, it becomes type 2. In type 3A, it's a big chunk, but still less than 25% of the anterior glenoid deficiency. In type 3B, it's more than 25% anterior glenoid deficiency. Hill-Sachs lesion, we all know, yes, it happens secondary to the anterior dislocation. And there's a crater which is formed on the posterolateral aspect of the humeral head. And the 70% incidence is in the first-time dislocators. That means they are going to get it. And 100% recurrence rate has been observed in the patients if you have an engaging Hill-Sachs lesions, which is treated only with the Bankart repair. That's very important piece of information for us. We also find combined bony Bankart and the Hill-Sachs lesions, and they have an additive and negative effect on the glenohumeral joint stability. Yamamoto came up with a glenoid tract concept where he said if there is a zone of contact between the glenoid and the humeral head during the elevation of the arm while maintaining maximum external rotation and horizontal extension. Now, this zone of contact somehow shifts from, I don't have a proper image here, I guess. No. I think it's getting hidden from the whatever I have here on the side. Sorry. Anyway, the zone of the contact shifts from the inferior and the medial part of the humeral head to the ciprolateral aspect whenever there is tracking. Now, this width of the track is from the rotator cuff attachment side of the GT, and it's almost 84% of the width of the glenoid at this maximum diameter. So the heel sac lesion remain within this track, there is a less possibility of off-tracking and hence the instability. Balg et al., they came up with ISIS, that is the Instability Severity Index score, which was based on the clinical characteristics and the radiographic findings to predict the risk for recurrent instability. Yang et al., they discussed heel sac interval to glenoid tract width ratio. If it's more than 0.7%, then these are the situations where you are likely to get significant higher risk of recurrent instability. So, gentlemen, with this, I would like to summarize my talk, and I would say that these are the list of the absolute indications for the surgery. That means when you have associated injury, such as rotator cuff tears, glenoid osseous defect of more than 25%, humeral head articular surface, or the proximal humerus fracture requiring surgery, reducible dislocation. Here you don't have any option; you have to go in, and when you are doing the open reduction, might as well stabilize the joint with your soft tissue or your bony repair as well. If there's interposed tissue or non-centric reduction, could be because of some interposed fragment, you need to go in and repair it. If there's a failed trial of rehabilitation, if the patient is still symptomatic, you need to go in. Or if the patient is inability to perform short sport-specific drills without instability. The relative indications are if you have more than 2 shoulder dislocations during the season, or patient is an overhead or throwing athletes, contact sport athletes. In such cases, you should also consider going for the early stabilization. Thank you so much for your patient hearing. I think we're going to take the questions at the end.
Yes, sir, we'll take the questions at the end. Thank you, sir, for the elaborate talk on the first time shoulder dislocator. Now, the second talk is by Dr. Rajiv Gupta. Hello, I'm audible? Yeah. Rajiv Gupta is the director of Arthroscopy and Post-Injury Center, Jaipur. The speaker is with the speaker in various national and international conferences. The first director of annual Jaipur Shoulder and Knee course. He is providing fellowship to joint surgeons interested in arthroscopy and arthroplasty. We will talk on Bankart versus Latarjet as first surgical procedure. Rajiv Gupta.
Thank you, Dr. Ashutosh, for a kind introduction, and I am really thankful to all U.P.Orthopaedic Association office bearers, especially Dr. Ashish, Dr. Anup, Dr. Vinay, and Dr. Neeraj. And am I audible, Dr. Ashutosh?
Yeah, you're audible.
Yeah. Today my talk is on Bankart versus Latarjet, which is good for which patient, and I think some slides you can find repetition with the previous Dr. Dhananjay lecture, and please bear with me. I start with case presentation. Young male, 22-year-old medical representative, had first dislocation 3 years back. After that, he had 2 to 3 further dislocations on abduction and external rotation. Apprehension test is positive, but no hyperlaxity as such. This is his scanograms. This is his CT. Hill-Sachs is mild, but no glenoid bone loss. We can appreciate with these two slides. Hill-Sachs is not much, and you can appreciate the good quality labrum on this side and some signal intensity changes starting from 6 o'clock to up to 3 o'clock. This is classical. I think it's a Bankart lesion extending from 3 to 6 o'clock. One more case related to my topic. Again, a young patient, software engineer, had dislocation 5 years back, and he had multiple episodes, especially in abduction and external. But important thing is he had dislocation in night also, and all the dislocations were reduced by himself. Of course, again on examination, apprehension and relocation test is positive, and again no hyperlaxity in that patient also. But important point in this patient is first night dislocation and reduced by himself. And his investigations are again big Hill-Sachs lesion, again the problem with the glenoid, and MR scan you can appreciate the Hill-Sachs with flat anterior glenoid. That makes that it's a bone loss on the both sides. How we can proceed with these patients, let's discuss. And today we are going to, because of some limitation in time, arthroscopic Bankart repair with bony procedure. If I talk about anatomy, we already discussed about the ligaments. Shoulder is one of the most unstable joint with a lot of movements at the cost of mobility. This is what we can compare inferior IGHS with hammock. One end is attached here, it is for glenoid, and other part of the this is for humerus. This is something we can call it hammock. If Bankart lesion is how we can explain, one end is get torn on the glenoid side in terms of antero-inferior labrum or glenohumeral capsule or anterior band of IGHL. This is what we call Bankart lesion. If it is get torn from other end, we call it Hegel lesion. And all we know, if we talk about in previous days, we have putty plate for the dislocations, some bony procedures, non-anatomical. Then we came to open Bankart towards the anatomical reconstruction, and nowadays we have arthroscopic Bankart repair, arthroscopic Latarjet, because of advancement in radio imaging techniques. If we go through the literature, which is best open versus arthroscopic, the literature says almost the results are equally in both techniques. Open is around 8.2% failure rate, and arthroscopy recurrence rate is around 6 to 4%. If we go through this paper again, this paper, this was published in JBJS, and the recurrence around 25%, especially in younger age group, as already Dr. Dhananjay told, because if the first dislocation in younger age group, chances of redislocation is around more than 80%. And in all these, important is collision sports, number of dislocation, and about the bone loss, whether it was on the glenoid or humeral or both sides. But arthroscopic Bankart repair is now gold standard for labral injuries, and what is required is a good bumper effect. We can get it by shifting capsule from to south to north. But all with important is patient selection and the requirement of patient, that they are high demand athletes, their use of shoulder is very high, and early intervention, as already Dr. Dhananjay discussed. Nowadays the emphasis is on the early intervention. Don't wait for second, third and dislocation episode, because after first episode, if second is there, then chances of bone loss is very high, and you can have to have bony procedures. Especially you have to concern with the contact athletes to whom you are operating and the demand, and of course if there is a glenoid bone defect or there is a bipolar lesion. After all, so most important is appropriate surgical technique to get the best result out of arthroscopic stabilization. Again, indication is very important for whom you are going to operate. position positioning, porter placements, labral mobilization, how you going to manage inferior labrum and capsule, and anchor placement. Few video showing how the anterior inferior Bankart lesion seems like. This is the video showing the labral injury, good quality labrum extending from 6:00 to 3 o'clock. And see the voluminous inferior capsule. That's why you have to take some bite with the capsule and taking the labrum so and do the south to north shift. This is UPSA lesion because of chronic dislocation labrum. Sometimes if we do the arthroscopy, we don't find any labrum at all is there, just only the capsule, and such type of patients are not a good candidate for arthroscopic Bankart repair, because you can appreciate the straight line of the glenoid, and lower down there is a Hegel lesion. This time the capsule is torn from the humerus side. See, the whole exposed muscles are over there. This is reverse of Bankart lesion. I do most of my almost all instability repairs in the lateral position because it's very comfortable to me. It's give me a free space to move around, and easily I can go with the posterior inferior quadrants. And of course, as compared to B chair position, I can go to my anterior inferior anchor placement very easily with lateral position. What is needed is first adequate interval of 2 cannulas so that they don't hinder by itself, because the spacing is very important, because one working portal you have required to do all the anchor placements, and that should be the very close to subscap. And after that you require mobilization of your labrum. See how good quality labrum is there, and you can get the best result out of this by repairing this. But in this patient, you see there is no as such atrophied labrum, only capsule is there. It is example of UPSA lesion. After that, what you require is you just mobilize till you can visualize, you can see the subscap fibers, and you mobilize till 6:30, 7 o'clock. Nowadays we are moving away from the little bit far away from 6 o'clock to get the best capsular tightening. And just you remove few of cartilage not to miss your anchor in the soft tissue, or after anchor misplacement and it comes out because of inadequate bone. All the literature supports arthroscopic stabilization, whether it is Joy de Beer, Sugaya, all the recurrence is around less than 5%. That shows that if you select your patient in a proper way, Bankart really works. But this is paper recently published in American Journal of Sports Medicine that shows that if you select your patient very properly, the recurrence rate is less than 8%. There is no bone loss. Of course, the emphasis was given anatomic proper technique. In summary, arthroscopic Bankart repair is a gold standard for shoulder anteroinferior instabilities as well as slap repair, but indications are very important. Early stabilization is now is there in the literature to avoid bone loss on the glenoid and humeral side. And of course, if you do the arthroscopic stabilization, always quantify your bone defects. If there is a multiple dislocations, there is a excessive laxity in tissue, there is not a good quality labrum, avoid doing arthroscopic stabilization. But overall, technique is very important, how you fix your labrum, because previously they used to do PDS, 2 anchors, but at least now the literature says that multiple fixation point is important to get good results. But after that, in spite of all good efforts in doing arthroscopic Bankart repair, still we are getting some selected patients, those are not reaching up to the mark, or they are failed in the Bankart repair. It may be because of age. Younger age, chances of failure is very high. Activity level, high demand athletes, collision sports, failure of Bankart repair is there. And involuntary and voluntary component is always there. Technical factor, failure to identify other causes, slab repairs, posterior labral injuries, and technical inadequate implant use, inadequate anchor placement, and of course inappropriate rehabilitation is always there. But important out of all these is anatomic factors, bone loss over the glenoid or humeral site. This is a paper published by the Joy de Beers and Bankart. They studied that if patient does not have any bone defect, recurrence rate is only 4%. If bone defect is there, 67% of recurrence is there. And inverted pier type of glenoid recurrence is around 61%. You can see this is how it is engaging in the anterior surface of glenoid. If you can appreciate Hill-Sachs lesion, the term engaging or non-engaging lesion was given by the Bankart in his paper. This is paper again published by Dr. Verma and Romeo, that for 1 to 2 mm of bone loss leads to 5% bone loss. What I mean is, if there is a 25% of bone loss on the anterior surface of glenoid, that shows that you have 6 mm deficit in the glenoid diameter. Again published in JBJS, what is less and what is more. This paper comes with at least 20% of glenoid bone loss is there, then you must think of any bony procedure. Don't attempt for only soft tissue procedure. This paper is published in JBJS. Reconstruction of glenoid concavity may be necessary in shoulder with anterior glenoid defect is more than 20% of glenoid length. Not all bone loss is of same type. If we talk about acute fracture, we can repair it with the double row, or there is a lot of techniques are there to incorporate this fracture fragment. If there is a old bony Bankart, still it is there, we can mobilize it, we can incorporate in the repair. So the procedure can be arthroscopic bony Bankart repair. But if there is a complete bone loss, complete resorption, no bone is there, I think coracoid transfer is the best option in such type of patients. The Itoi and Yamamoto came with the glenoid tract concept. If there is a significant glenoid bone loss, you can appreciate with this picture, arthroscopic picture, flattening of the anterior margin of the glenoid. Hill-Sachs lesion become more important with concomitant glenoid bone loss. Itoi, Giovanni and Bankart with the glenoid tract concept that Dr. Dhananjay already discussed. We have on-track, off-track lesions. On-track lesion, that is the Hill-Sachs index is less than with the glenoid, and we can compare with the example of porthole with the vehicle tire. If porthole is small, tire is big, then we can call it on-track because it is got unnoticed. If porthole is big and tire is small, then we can call it off-track lesion. Tire is a humeral head and the glenoid is a porthole. And there is a various method to calculate Hill-Sachs index, what is there. The important point is, it is not the depth, it is this is rotator cuff insertion, and this is the margin of Hill-Sachs lesion, how far it is. This is important. The far it go, on medial on more, then chances of off-track lesion is there. What is the warning sign in spite of all this studies and the discussions? Young age, of course, we all know that if the patient is younger, chances of recurrence is very high. Again, overhead sports has a collision, sports has a high chances of risk. Multiple dislocation because that leads to bone loss and atrophy of labrum. Mid-range of motion, what I mean is, if generally what happen in 90 degree of abduction and external rotation, dislocation happens. If the dislocation happening in the mid range of motion around short abduction 90 degree but short of external rotation, that shows that patient has some bone loss. And nighttime instability again give you an idea of about bone loss. We can quantify bone loss by a lot of methods, Sugaya, and we have some arthroscopic way with the probe we can measure the bone loss. But in a straightforward, in clinical practice, if you are doing a arthroscopic examination and you find a straight line over the anterior surface of glenoid, and this pear shape is part that shows that at least patient has 15 to 20% of glenoid bone loss. Then it comes how to manage all these. We have on the glenoid side, we can repair Bankart, we can do the Latarjet, we have ICBG graft, and on humeral side we have Ramplissage, or we can do the OATS. In paper, this 2010 gives us idea about how we can manage this glenoid bone loss. If we have 15% of glenoid bone loss, patient is not high demanding, we can do the standard arthroscopic Bankart repair. If it is a bony Bankart, we can incorporate this. But important thing is liberal use of anchors. At least 3 to 5 anchors you can you use, and you tighten your posterior, inferior, and anterior inferior capsule also. If the bone loss is around 15 to 20%, again arthroscopic repair is there, but you have to add on Ramplissage. But if there is a bone, if it is a bone is there, you can incorporate this. But high demand patients, for collision sports, you have to do the bony procedure. If it is more than, only option is bony Bankart. Again, same paper, same way, how we can manage the bipolar loss. If we have glenoid bone loss less than 15%, it is more than 15%, with non-engaging, engaging lesion. If it is a non-engaging, we just do the glenoid bone reconstruction. If it is engaging, we have to go with the arthroscopic or open stabilization Bankart repair with Ramplissage. If it is a bone loss, then how we can manage it? We have to do some bony procedure like coracoid transfer. Most of the time it is the glenoid based surgery is enough. Rarely on the humeral side we require, because all is on the glenoid side reconstruction. We all know this man, Michael Latarjet, 1956. He did 9 patients with coracoid transfer fixed with single screw and came with Latarjet procedure. I prefer open Latarjet. There is now literature is there that comes with convincing result with arthroscopic Latarjet. I have a small cosmetic incision, all we know, and this deltopectoral interval we all know with our residency time. We don't have any graft site morbidity. The learning curve is not too long, and the complication, all we know that Latarjet has very rare. This is how we do coracoid transfer to inferior, and the important thing is the graft must be on the below the equator, not on the above at the level or above the equator. The principle of Latarjet is triple locking effect. Sling effect is given by the subscap and the coracobrachialis as well as the biceps tendon. Bone effect is to increase the arc of this glenoid, and the last one is Bankart effect when you repair the capsule with the coracoacromial ligament. There is a lot of confusion still in the literature that how to cut the subscap. It is split, it is a L-shaped incision, whether we have to keep the bone block intracapsular or extracapsular, how to keep the coracoid, it is on the as a arc described by the Joy de Beers, or we can put it flat on the glenoid anterior surface, because in our patients the coracoid is not so big. But Bankart in 2002 gives this congruent arc modification while doing Latarjet. The important where to put our the bone graft, if it lateralized or it is medialized. Important thing is we have to flush our graft with the glenoid, because if it is proud, it increases the pressure by 250 times and leads to glenohumeral arthropathy. Latarjet outcome, again 30% overall complication rate with this paper, but it is the only one that comes with, it's a sole, it's a single study. and we have few complications, especially with the axial nerve, musculocutaneous nerve, graft resorption, and of course reoperation. But in high demand patients with bone loss, I think Latarjet is a good option. Rehabilitation, if we talk about in the Latarjet, of course patient require abduction sling, immobilized for 3 weeks, and by 6 weeks patient don't use sling, and we can start the passive range of motion exercise. We have to avoid the external rotation and extension to get healing of the subscap and to avoid any strain to the biceps and coracobrachialis. Strengthening exercise started after 6 to 8 weeks post surgery, and we have to emphasize on subscap, pec major or minor muscles, biceps brachii by 3 months. When full passive and active shoulder range of motion and adequate strength achieved, we can allow patient to our sports. In summary, glenoid bone loss is a significant risk factor for recurrent instability following soft tissue stabilization. If patient has nighttime dislocation, has multiple recurrence, and the dislocation or apprehension sign is positive in mid-range, I think it is a warning sign. You be cautious regarding bone loss. Of course, CT scan is very important in deciding the bone loss, how much to quantify it, and of course most of the time the bone loss on the both sides, but we can manage it with the glenoid only. Take home message: arthroscopic Bankart repair is a gold standard in anterior-inferior instability, but number of dislocation increases the bone loss on both sides and labrum get atrophied. That's why if the patient has second recurrence, we should advise them surgery. In selected group of patients, even only 12 to 50% of bone loss may require bony coracoid procedure. Thank you for your patience hearing.
Thank you, Dr. Rajiv, for the excellent talk. Now we have third talk by Dr. Pradip, Assistant Professor, PM Hospital, Mumbai. His various publications in his bread. He has written chapter in textbook of spinal infection and trauma. He has conducted various courses on pelvic fistula, spine, trauma. He is also a executive member of Indian Orthopaedic Society. His talk is on Vinay Open Rotrater of repair, how I do. Dr. Pradip.
Yeah. I hope I'm audible.
Yeah, you are.
Okay, so thank you UPOA for giving me a chance to share my experience about my technique of doing a mini open rotator cuff repair. Okay, so this is the place where I work, that's KM Hospital. I think most of you may be knowing this. I must basically express my gratitude towards my teacher from whom I have learned this technique of mini open rotator cuff repair. Of course, I modified later on, but my initial learning was with Dr. James Chow in USA, from which I had learned the technique. Okay, so first a few slides of my presentation would be making a case why to do a mini open rotator cuff repair in today's time when everybody is trying to go for an arthroscopic rotator cuff repair. Is it an absolute procedure? Does it have basically a place in today's time? So that current review of literature will tell us what is the current stand of mini open rotator, or for that matter open rotator cuff repair. Okay, so this is the thing which I say again and again to my residents again. Just an ability to perform a technique is not an indication to perform the same among patients. So if you are just know one to do it by one technique, doesn't mean that that's the indication. So this applies for many of the procedures which are nowadays done more and more arthroscopically. Just because we are able to perform it arthroscopically doesn't mean that it's an indication to do it by the same, unless there is a clear-cut advantage of that procedure to be done, then it should be done. So when there are two techniques available to treat one thing, which one you should choose? So I think it is pretty simple. The one which gives better results should always be chosen, no matter what is the difficulty level of that technique. However, if two techniques are giving you similar results, then a lazy person like me would choose a simple technique rather than a difficult technique. And of course, if something is cost effective, I would go for that rather than a costly technique. Okay. So proposed advantages of arthroscopy are: number one, better outcome. there are less post-operative pain, maybe less stiffness, and it's cost-effective. These are the things which are being hammered onto our mind again and again. That these are the advantages by which arthroscopy offers us. However, let's now try to see what the literature is saying. Now, I'm going to quote only the systematic review, meta-analysis, and grade 1 or the randomized control trial. So most of these studies are like grade 1 or 2 evidence. So yeah, so this one, systematic review, a meta-analysis of arthroscopic mini open rotator cuff repair. It gives similar outcome, can be chosen interchangeably. Another article, arthroscopic versus mini open. Again, there is no differences in outcome between arthroscopic and open rotator cuff repair technique, and they can be again considered alternative. Another article, again, AJSM high impact factor journal, again, arthroscopic versus mini open, a comprehensive and meta-analysis. Again, there is no difference in outcome. So we are now we are now basically talking about outcome. So of course, there is no difference in outcome when you are thinking all arthroscopic versus mini open. Again, another article, RCT of 100 patients. Again, as far as functional outcome, pain, range of motion, complications, there are no significant difference between arthroscopic versus mini open rotator repair. And in fact, another article, arthroscopic versus mini open. Again, the functional score both increase in both the groups. However, there is no significant difference. Again, they have again equal outcome except for higher retear in arthroscopic repair group. So that again is an interesting finding out of this meta-analysis. Another article, again, there are n numbers of article. If you go and search, again, they keep on appearing again and again. So again, quality of life, arthroscopic versus mini open. There's no difference in the subjective and objective outcome measures between the mini open as well as mini open or arthroscopic rotator cuff repair. Again, this is a midterm follow-up. There is no statistical difference between these two. So this was, as far as outcome, I think it was pretty clear that arthroscopic versus mini open rotator cuff repair. I don't think so there is any difference between the outcome. Now, what about early phase pain? So that is again one thing that has been told to us, that in early phase arthroscopic is much better. It gives less pain, but does it really? Is it really the case? Again, early post-operative outcome in RCT by mini open or arthroscopic, there is no significant difference. Another systematic, there is no statistical difference between this thing as far as early phase pain is considered. Again, another article, this thing, there is no difference. There is no different this thing, and they are equivalent regarding outcome in this period. As far as stiffness is concerned, again, it has been told if you do open technique, it will lead to intractable stiffness. Again, 2011 article, there is no cases of intractable stiffness, and there is no case of deltoid damage in cases which were done mini open technique. As far as cost is considered, now this is pretty important in our country, of course, in the setting which I practice again. So what is the cost difference between the mini open versus arthroscopic? Of course, it is a no-brainer. There is significantly less operative and significantly less expensive as compared to the arthroscopic technique. Again, another article which is this thing, that arthroscopic and mini open has same clinical result, but arthroscopic has a higher cost as compared to mini open. And as far as cosmesis, now look at this. Our patient, they hardly it does not matter to then what kind of incision is this. So in this patient, the incision is so small. Many of the patient would have a bigger BCG or a smallpox scar than this. And this really does not matter. Of course, none of our patients wear this kind of dresses. So again, that incision does not matter to none of us. So coming to the rotator cuff repair, now what do you say that what is a good rotator cuff repair? A good rotator cuff repair is the one which restores the anatomy to the fullest, whatever is the best possible way to restore the anatomy, that will be the best. And the second thing is you create a good biological environment for that cuff to heal in that position. So if you respect the biology and recreate the anatomy, then I think that would constitute a good rotator cuff repair in my opinion. And whenever you want to do a rotator cuff repair, it can be good or bad, and the good rotator cuff repair can be arthroscopic or mini open this thing, and the same way it can be bad also. So arthroscopic and mini open, it can be bad also. So what we need to focus is on doing a good rotator cuff repair. It does not matter whether you do it arthroscopic or a mini open. So just because you are doing it mini open does not mean that the results are going to be inferior as far as the repair is good. On the other hand, just for the sake of doing arthroscopic, if you are doing a bad repair, then the results are going to be bad. So arthroscopic rotator cuff repair, we know that it's a technically demanding. It requires time. It's the learning curve. It is instrumentation dependent, that adds to the expense sometimes on the surgeon side, because many of the time surgeon has to procure these instruments. And of course, the implant which are needed for arthroscopic rotator cuff repair are much more precise and much more costly than a mini open rotator cuff repair. So my indication for mini open rotator cuff repair today, this thing is whenever I want to decrease surgical anesthesia time, such as age, poor general health, patient has economical issues, and I would do it for supraspinatus repair or supra plus infra, or many of times superior subscap repair also can be done with this, including the bicep pathology and the subacromial decompression. So the traditional incision which was described earlier days, where the mid-acromion straight incision like that, of course this incision gives us a problem, because if you split the deltoid in this line, the proximal most split is going to be hindered by the acromion. So then we have another incision, that is horizontal incision along the Langer's line, that is along the horizontal margin, horizontal line along the lateral margin of the acromion. This is a good incision. It is very cosmetic incision. It gives you good exposure. We can always convert this into a age-old Henry's exposure or something like that. However, and it is along the Langer's line, so it gives a very good scar. However, what I do most of the time is this kind of incision, not the horizontal. This is the horizontal incision, but I do this vertical kind of incision. It is cosmetically not as good as the horizontal incision, but it gives me an versatility to expose it distally and proximally whenever it is possible. So I take an incision that is along the anterior, a line that is along the anterior margin of the clavicle. So if you take the anterior margin of the clavicle, trace it down, that would be the line of the incision. So the incision starts around a 0.5 to 1 centimeter proximal to the anterior angle of the acromion, and in line with that, it goes around 2 to 3 centimeter distally. So typical incision is generally 4 centimeter. You can always increase it if the patient is hefty, but typical incision is generally 4 to 5 centimeters. Now, if you see axially nerve, we know that it's around a 4 finger breadth below the acromion, but the acromion axial nerve course from posterior to anterior, it goes much more distally. So anteriorly, if your incision is more anterior, then we are around 6 centimeters of safety thing when you take the incision. So axial nerve is much more distal if your incision is more anterior. So after taking the incision, I generally infiltrate it with the adrenaline solution, that is 1 in 3 lakh. Sometimes I would do it, sometimes I don't. Especially if there is a early bleeding, then I would do that. If not, then I would use this same solution, and I will use the gauze piece soaked in this solution for later on usage during the surgery. So after that, we cut the skin and subcutaneous tissue in line with the incision, and then we expose the underlying deltoid. At this point, we do undermining of the incision in all directions, so that you can expose the deltoid fibers in their length, along their length. So you undermine, so that will give you a mobile window of the skin also, that will improve your retraction later on during the surgery. So just 1 centimeter in 1 to 2 centimeter in all 4 directions, you undermine the skin incision over the deltoid. That will help you in identifying deltoid morphology much more better. Okay, so once you have on the deltoid, typically you just require this vertical incision, that is splitting between the anterior 1/3 and posterior 2/3 fibers. So we start from the anterior angle of the acromion and go along the line of the deltoid like that. So that is a typical incision most of the time which is required. Sometimes you may have to take a centimeter or so horizontal incision, especially so when you are suspecting an impingement to that patient, and then when we want to expose that part of the acromion, excise that part of the acromion that is anterior to the anterior margin of the clavicle. So in that case, you may have to take this small horizontal extension to your this thing also. Otherwise, most of the cases you will just be okay with just horizontal vertical splitting of the deltoid in between the anterior 1/3 and posterior 2/3 fibers. Okay, so this is how we mark the this thing. So this is the incision. This is the split of. This is the line where we find that raphe, and then we just split the raphe like that. We just split the raphe like that. So we don't want to go like this. We want to go more anterior like this along the anterior 1/3 direction. So if you are going much more posterior, trying to go toward the center of the incision, and we are cutting through the deltoid fibers, we don't want. We want to split the deltoid fibers. So our incision is much more anterior along the anterior margin of the clavicle. After that, we expose the anterior angle of the acromion, and the hook acromion in type 3 morphology of the acromion can be appreciated here if it is present. And I will show you videos later on. And then in that case, we can just take a small nibbler and osteotome to chop off that fragment of the acromion. Now, complete subacromial decompression can be done at a later stage as opposed to the arthroscopic, where we begin with subacromial decompression. The reason for that is that, you know, if you do subacromial decompression at this point, that can lead to oozing of the blood, and that can, you know, increase your surgical time. So you don't want that. We want bloodless field. So that's why we want to do a subacromial decompression at the end of the procedure rather than at the beginning. Just when sometimes the subacromial space is so stenotic that sometimes it may become difficult for you to work there, then you can just chop off the anterior part of the acromion so that it adds to your space, and it makes your working much more better. And at next stage, we clear off the bursa. So if the bursa is too much hypertrophic and this thing, you can take it off. Nowadays, I would like to just split the bursa, and with the gauze piece, I push it posteriorly and anteriorly, and at the end of the procedure, I would just suture up the bursa if it is not inflamed and thickened. So we know nowadays, recent literature which show that the bursa gives us a lot of vascularity and for the cuff healing, and most of the even arthroscopically, there is a lot of trend toward bursal preservation. So this is pretty easy with mini open, because you can just swipe off the entire bursa posteriorly, and then you can just close it at the end of the procedure. Okay, so this is the bursa. Okay, so that video is not working anyway. So that's the bursa. So after you are taken off the bursa, we expose the cuff under that is there underlying. So we know that cuff tear can present to us with different morphologies. So the correct cuff morphology need to be identified. So typically what we see down there is the cuff tear that is at the greater tuberosity. Just anterior to that is the bicep tear if there is a tear extending into rotator interval. If there is a tear into superior subscap, then we'll see that also. Sometimes the bicep also can be subluxated here in case it is a superior subscap continuous into the supraspinatus tear. And we can just rotate the arm internally, and we can expose the posterior part, and we can judge whether the infraspinatus is intact or it is torn as well. We can tag the cuff and look it from underneath to see if there is a lamellated tear also. So the lamellated tear also is very well visualized through a mini open technique. Once we have seen the cuff, we try to identify the cuff morphology. So typically, this is a very classical diagram. We mark point A, point B, and point C, and we can just try to approximate point A towards point C towards point A, trying point B in between. So based on that, we can know that whether it's a reverse L-shaped tear, a T-shaped tear, or a simple L-shaped tear. So that is very important. So this mini open technique gives you a panoramic view of the cuff tear right from the top. It gives you a very easy way to manipulate the cuff to judge the exact anatomy, and in my hands and in my opinion, that is a very important advantage. Of course, it can be done arthroscopically as well, but it takes much more time. It can be done very easily through arthroscopy with the mini open. So we can see there, here is the cuff tear. So that's the cuff that we see. and I'm just trying to approximate point C towards point A, and I can now very well know, just hold the cup there and try to, when I'm trying to approximate it, I'll know that this is a L-shaped tear and not a T-shaped tear. So I'm trying to put it posterior, it cannot go there, but when I try to push the anterior, it comes nicely and the entire humerus get covered. So this anatomical identification of the cuff tear morphology is extremely important, and it is very well visualized with mini open technique because it gives you a panoramic view directly from the top with the ability to manipulate the cuff in whatever direction you want. So this is another cuff tear morphology. We can see that, you know, this is definitely a T-shaped tear, a tear that is in crescent shape. We can manipulate the two limbs of the this thing. And we can know that this is a T-shape. So these different ways by which the cuff tear can appear can easily be decoded, and you can really identify the cuff tear morphology. Here again, I'm trying to see how the cuff can be beautifully seated in its original place. Another example of a cuff tear morphology. So here we can see, so some very massive cuff tear in this case. So this has a bicep tendon that is dislocated into the joint. That bicep tendon, which has been marked by this thing, and this is a superior subscap tear. This is a subscap tear, and this is a supraspinatus tear. So it's the supraspinatus tear going through the rotator interval tissue and into the superior subscap that can easily be identified with mini open technique. We externally rotate and the entire subscaps come in front of you. So we know that how difficult subscap repair can be arthroscopically, but with mini open it is very, very easy. In fact, it is much more easier than the supraspinatus repair, because with just simple external rotation, the entire subscapularis incision comes to your comes into the face of the incision. So that is another advantage of mini open technique. Though that the incision is smaller, with the rotation of the humeral head, you can bring forth whatever part of the humerus that is needed. So you can just take we can bring the LT in front, we can take the posterior part of the GT in front, we abduct it, and we can take the distal part of the GT in front. Another advantage of doing mini open technique is that, you know, as opposed to arthroscopy, which is done in 30 to 40 degree abduction in lateral position, most of the mini open technique are done in adducted position, and, you know, in fact the repair also is done in an adducted position. So we don't basically repair the cuff in a lax position. So whatever is the maximum tension that is there on the cuff, it is at the point of the repair. Later on, the tension in the cuff do not increase because it has already been done in an adducted position. Okay, so next step that we after identifying the cuff morphology is debridement of the cuff and preparation of the greater tuberosity. So we remove this sclerotic bone, so that is the reverse subacromial decompression, what has been talked of. The lateral margin of the rotator, the greater tuberosity, which is a reactive new bone formation, needs to be taken off. It can be done with a burr or it can be done with a nibbler. Point should be taken that we don't want to remove this part of the bone, this cortex, because we know that the cuff will not heal good on the cancellous bone. We don't want to extensively decorticate this horizontal part just lateral to the cartilage. What we are going to take, taking off is this sharp lateralmost edge of the greater tuberosity and not the paracartilaginous cortical bone. There, what we can do is make small drill holes, what is called as the crimson duet, to get the underlying marrow come forward, which is going to help you in healing. Then you can just simply rasp that area, don't decorticate it, just rasp that area to find out a micro bleeding, you know, the kind of paprika sign or micro bleeding in that. We can do micro fracture, as we have said, and we of course we have to do rounding of the greater tuberosity, what I already told as a reverse subacromial decompression. Okay, then there we have various repair technique which we can do is transosseous technique, single row, double row, whatever is your way of repairing a cuff which suits in your hand, you can do. What I do is generally a modified technique, which is a double row technique, but rather than using a lateral row anchor, I use a horizontal transosseous tunnel. So generally, the transosseous technique, it includes the vertical tunnels, but here in this technique, I use a horizontal tunnel, and that gives me a nice double row effect. I'll explain on to that. So step one is that you expose the cuff like that. So that is the cuff that has been exposed. We take the holding sutures and try to identify the cuff morphology. Then we pass the medial row anchor as we are going to pass in our standard double row repair or single row repair. So we pass it just at the articular cartilage margin in a dead man's angle. And then we pass the suture strategically through the cuff. Now, this is again a very important advantage of mini open technique, because as opposed to arthroscopic technique, where we are just passing on the sutures with the where the cuff is in retracted position. Here we can just reduce the cuff with a small traction suture, and then just at the point where the cuff is approximating to the anchor, at that point we can pass. So this is a strategical retrieval of the sutures. We do not produce uneven or undue tension on the cuff when we tie these sutures. So this is extremely important in my opinion. I think there's some background noise.
Hello, kindly mute yourself, Dr. Anupam.
So after we have done the strategical retrieval, so this is the way by which we can do strategical retrieval. So this is a traction stitch which is keeping the cuff reduced, and once the cuff is reduced, we are just taking off the suture at the point where the cuff is coming at the anchor. So now I am not blindly passing the suture. This suture entry point is strategic, just at the point where the anchor is approximating the cuff, so that we are not going to have undue tension on the cuff when we are going to tie it off. Okay, then we crisscross the suture just as our speed bridge technique. We know what is the speed bridge technique, so we can crisscross the sutures. If required, we can tie a knot like a suture bridge technique, or in many cases I would just crisscross. So it is extremely patient specific as far as depending upon the cuff tissue that is available. Sometimes I would tie a knot, sometimes I would just do a speed bridge kind of a repair. So we cross it. So just like that, we cross the sutures. The anterior sutures goes posteriorly, posterior sutures come anteriorly. Then we develop horizontal transosseous tunnel. So how to develop that? We take help of this lateral edge of the bicipital groove. We know that this bone is extremely strong bone. We make a small hole with a K-wire and just take a simple 5-number ethibond needle and try to pass it through that hole, and it will come out posteriorly. And that is the way we are going to develop a horizontal transosseous tunnel. Now, many of us who are doing a vertical transosseous tunnel, they have noticed that when we tie the suture, the tunnel tends to cut through, and that is because we are working in a very weak area of the greater tuberosity. This, however, when we are doing a horizontal transosseous tunnel, we are going as much as away from the lateral margin of the greater tuberosity, so we have good cortical bone. So as distal as possible, we should try to make this tunnel as distal as possible to basically recruit the strongest quality of bone that is possible. And after that, we just retrieve the posterior suture anteriorly, and then we will tie it off with the fellow sutures, and that will give you a nice double row effect. So instead of passing 2 anchors here, I would make a horizontal transosseous tunnel. Of course, if only one wants to use the anchor, they can always use the anchor. I am I try to be a little bit conservative on the side of implant, so I do this technique. It also saves a lot on the cost of the patient, whereas lateral row anchor are costly. So anyway, we can use anchors also if you want to use anchor, and that will give you a nice double row effect with a compression of the cuff at the footprint. Okay, that is how it looks at the end of the surgery. We see this nice crisscross, and all the knots which are there away from the acromion and during the abduction, because they are very much more distal. And that is the end of the surgery. The incision is typically hardly 4 to 5 centimeters, and really that does not bother the patient much. So a few examples like this. So this is a massive cuff, we can see. So this is a traction stitch, and now we can see that this is a massive cuff tear, the supra and infra, both this thing on to a very strategically placed just at the cuff. And this is how it can be repaired with the same. So we can nice coverage of the sutures are away from quality of repair, which is anatomy. Okay, so this is a typically this thing. So this is a medial row, this thing anchor or a double row, single or two anchors, and then we crisscross it, and we can use a transfer tunnel as a double row. And these are the results to the patient. They do fantastic. So this is another case. Now this is again a massive cup. You can see that this is a massive cup, and the I think again there is some noise there. So this case we can very well appreciate that there is a lateral downsloping of the acromion as well, and there is an impingement there. We can see this is definitely a cuff, a very big cuff, and this is what I was talking about. This is anterior the acromion, and now look at this. Just to orient. This is superior. This is inferior. This is anterior. This is posterior. So this is the acromion. That is the sharp edge of the acromion, and this is the cuff. And we can really simulate how it is. So we just forward flex it, and we can see that how the cuff is approximating to that anterior edge of the acromion, and that how is going to cause the cuff tear. And this is after taking off the acromion prime time morphology. So it's a massive cuff with a lot of tissue damage there posteriorly. So we can judge our repair. We can try to see if there are any lamina, and then we can even utilize the lateral tissue, which is a type 2 kind of a tear, rather than completely debride it. You can utilize that in the tear as well, cuff repair as well. And this is at the end of the repair. So these are the way how which we pass the suture strategically. So we can see that multiple sutures have been passed through the anchor, through the cuff. Strategically, they are passed, keeping away the space in between them. And when we cross this suture, and this is the way we retrieve the suture through the by using the ethibond. So this is suture in suture technique. We take ethibond and pass this suture through the needle. The needle is, and with this back from back to front. So from this go from here. So these, yeah. So these are the sutures which go posteriorly, and from there they are through the tunnel. They are retrieved anteriorly like that. So this is how, and this is at the end of the repair. See that such a massive cuff tear, but with very simple and very good secure panning out of the sutures can be done on this cuff repair by strategic placement of the sutures. And this is a small incision, again, not a very big incision, hardly 4 to 5 centimeters, and that works very well. Now, high-grade bursal tear like the bursal surface tear like this. Again, we can see that lateral downsloping of the acromion, anterior spike of the acromion, and that leads to the high-grade bursal tear going into the complete tear. So this is the acromion, and that's the cuff tear to the position of the traction. When we leave the traction, it just matches to the area of the acromion like that. So it really gives us another advantage in deciding whether we are going to do a subacromial decompression in a said case or not. So this is a cuff tear. Again, we can see that that's a high-grade bursal surface tear with completing at one point. And then we can just keep the intact bursal intact articular fibers intact, just pass the anchor through those fibers and just repair the bursal side only like that. So that advantage of versatile repair of the cuff again is possible to you, because you are just looking at it end on and you can manipulate in the way you want. And this is the function of the patient at the end of 1 year, and they really get a very fantastic outcome, because if you repair it anatomically and preserve the biology, then no matter what technique you are using, the patient gets fantastic result. Okay, another case, a massive cuff tear. Now this is the case where we can see multiple lamellae and multiple kind of slits into the cuff tear, into the cuff. So different morphologies of cuff can be possible. So you are the point of showing multiple cases is that all these cuff morphology can be very well visualized, and that is right under your eye, and you can repair it the way we want. It can be a patient specific in the repair pattern that you can create. They did not follow the same for every patient. You can individualize the repair construct as is ready for the as is suitable for the patient's morphology. So this is how it can, again, the same cuff can be repaired very well, and multiple sutures panning out covering the entire footprint. And this is nowadays we are just closing the bursa again. So we are not taking out the bursa. So we can see that this is the bursa now. Nowadays we are just cutting the bursa, splitting it, and at the end of the surgery we'll just close the bursa back to its own position. And this is the incision. Okay, then we can have different configuration. Let's say anchorless. Now this is Dr. Kuroda has described this configuration arthroscopically. We can just create the same configuration using the entire cuff tear. In this case was just done by 2 fiber wires. So this is a very cost-effective method of repairing even a massive cuff tear like this. So this is very easy to do with a mini open technique. We don't require any kind of jig as it is being required to arthroscopically. So this same morphology can be created very easily by mini open technique. If the cuff is too much retracted, now we're going to follow the same principle as it's been described. We can just medialize the cuff and do a single row repair like that. It can be done. You can do the same thing, or you can just do a simple single row repair. So in summary, mini open rotator cuff repair is a simple technique. It allows anatomical repair. It is very cost effective. Deltoid splitting is not at all morbid, because you are just splitting it. You are not cutting the deltoid. And to improve the ease of the surgery, use arthroscopic instrument, different suture shuttler devices. So just to summarize everything, I'm not sure whether the audio will be visible, but on a comical note, I would like to just present this video. And mini open super. Thank you. I think you're not audible.
Thank you, Dr. Pradip, for the excellent talk. And we all, UP and all orthopedists, have learned this technique. This technique is done by all orthopedic surgeons. Thank you, Dr. Pradip. There any questions?
Yeah.
What is Vinay?
Dr. Ashutosh, can I ask one question? Dr. Anupam.
Yeah, Dr. Anupam.
Yeah, just I need that every time in a mini mini incision, there's anchor is needed, or can stitch it by a simple thread or at the bottom.
As I said, you can use any cuff repair technique that is being suited to you. You can use a simple vertical transverse tunnel. You can use the Kuroda technique, which I had just shown at the last. Or you can, you can just make a gutter and age-old technique. Just pull the cuff into that gutter and tie it laterally. Whatever technique which you want to do, it can be possible through a mini open technique.
Pradip, Dr.
Yes.
Pradip.
Thank you. Hi. Yes.
There's a question.
Yeah.
So how do you address concomitant pathologies with cuff when you're doing mini open surgeries like bicep, like AC joint, like suprascapular nerve release? How do you address all these pathologies?
Okay, so that's a very good question, and again that has been asked again and again to me. So number one, arthroscopy is not contraindicated. You can, if you want, you can always do it arthroscopy assisted. You can add it. Number two, is bicep pathology is very well, actually it is right in front of you. To the cuff here, you can just see the bicep there. You just take a probe, and we can just take out the bicep. We can completely visualize from the glenoid till the groove. And whatever you want to do, you want to do a proper tenodesis by drilling a hole into the bone, or soft tissue tenodesis, which is my preferred technique. I can do that. We can even do superior capsular reconstruction. So there are subacromial spreaders that are available. Let me see if I can show you subacromial spreaders. So there are subacromial spreaders that are available that can be used. Let me just show you.
Do you always do a bipo?
So can you see this? This thing. This is my instrumentation tray. So can you see this? I'll show you. Can you see this these instruments here? These are the subacromial spreaders.
This is custom made or some?
No, these are proper subacromial spreader that are available.
Okay.
So you can, if you want to use this, you can basically completely basically depress the humeral head, and you can see the glenoid right in front of you. So that is regarding this thing. Now, as far as AC joint is concerned, and I asked this question to everyone who is asking this question, that whether you're going to address the AC joint, is it an intraoperative decision? I believe everybody is a very good clinical examiner, and they can assess the radiology very well. And I think everybody will agree to me that whether they want to address AC joint is a pre-operative decision than an intraoperative decision. So even if it is an intraoperative decision, we can just increase our incision a little bit more proximally, and we can just expose the entire AC joint. In case you are taking a decision of addressing AC joint, you can just change the incision to a maxi-mini. We know that the maxi-mini approach, so go a little bit more anteriorly directly onto the joint, on the AC joint, and you can address the AC joint right at the same time. So that is regarding the AC joint, this thing. Other concomitant pathology like scapular nerve release, of course, that for that you need to do a arthroscopy assisted this thing. So there are open ways of suprascapular nerve release that are described, but I don't want to do that. Whether you want to do a suprascapular nerve release, that is again a controversial question, and that is not the domain of this talk. But if at all, you can always do it arthroscopically, because it is in lateral position. It's not contraindicated. Means you can always do arthroscopy. Previously, I used to do arthroscopy to begin with, like we'll put the scope, we'll diagnose it, and then do the mini open rotator cuff repair. But then I realized that it is not adding much to my this thing. In fact, the continuous use of the arthroscopic fluid later on complicates the procedure. So if at all you want to do it, you can do it at the once your procedure is complete. When your procedure is complete, patient is already in lateral decubitus position. You can just take the this thing and complete your age-old procedure, whatever arthroscopic procedure you want to
do. May I ask a question?
Yeah.
Yes, sir.
Ashutosh?
Yes, sir.
To Dr. Nemade, I have posted in the chat box also. So your positioning for doing the open repair cuff is with the arm abducted in lateral decubitus, or the arm hanging down?
No, it is not arm abducted. The patient is in lateral decubitus, slightly more supine, so that the glenoid is rightly facing upwards like that, and the arm is actually adducted. It is just tied with the traction, but it is not abducted like this. I don't want the arm to be abducted so that GT goes in. I don't want that. I want the arm that is lying on the body so that the entire GT is exposed to me. That is number one. Second thing, advantage that it gives me is that, I am not basically repairing it in abduction. So if we repair it in abduction and then later on we bring it, it's going to pull the cuff more. I don't want that. So whatever traction that I want to give should be on the cuff should be the maximum during the surgery. I don't want any more traction to happen on the cuff at the end of the surgery. So that is another reason I would do it in an adducted position and not an abducted position. The problem occurs most of the time is, you just try to extend it more. if the patient is a little bit more supine position, if the arm the hand goes more it extended more, and that gives you a lot of problems. So to avoid that, make sure that the traction, whatever you are tying the hand to, I just try to the normal saline stand. It is a little bit more anterior because the anterior deltoid is more relaxed, and you can access it much more anteriorly.
Exactly.
Yeah.
Dr. Pradip, do you always do biceps tenodesis to all the panelists?
No. So it's
You
a
always do the biceps tenodesis.
No, it's
a pre-op decision.
It's a pre-op and intra-op. Of course, we can see pre-op and intra-op also. You can inspect the bicep, and whatever you want to do, we can do. I don't do a tenodesis as if by drilling the tunnel and passing the screw. I would just take the bicep and we'll just incorporate into the repair, the distal vein into the repair, or just tie it with the surrounding tissue. A lax kind of biceptal tenodesis. Dr. Amravati can tell us about the keyhole technique.
I want to ask it to Dr. Amravati also. He's there.
Yes. So keyhole technique also, if you want, you can do it to the same incision. Yes.
One question to Dr. Pradip. If you do the arthroscopy sub-acromial decompression or by the mini open decompression, how you feel the satisfaction of this open and mini, arthro and mini?
I'm sorry, I didn't get your question. I got that you
decompression if you like to do by the mini open and in comparison to the arthroscopic decompression, how you feel this satisfaction?
So number one, arthroscopic subacromial decompression and many we have many stalwarts here, and still it takes at least 10 to 15 minutes, if at least which I have seen many people. At arthroscopic subacromial decompression take at least 10 to 15 minutes. Mini open rotator subacromial decompression take hardly 2 minutes. Okay. Not more than 2 minutes.
It is gratifying.
It is extremely gratifying. Number two, which which is I'm going to make a point, and it is debatable. I don't know whether it is advantageous, but yes, what I do is generally I take off the periosteum of the acromion, the undersurface of the acromion. I go subperiosteally, take off the chunk of the bone, and reapproximate the periosteum back. So at the end of the procedure, the cuff is not exposed to the raw surface of the undersurface of the acromion. These are the periosteum still remains there. So I don't know whether how much significance does it take, but yes, that's what I do.
Thank you.
Dr. Dhananjay? Can I ask one question?
Yeah. Dr. Dhananjay? I think
Dr. Pradip, can I ask one question?
Yeah, sure.
Whenever you make a horizontal tunnel in the GT, how you pass fiber wire or super
5 number T-bone. 5 number T-bone.
And
just take a 5 number, just make a small, first take a K wire, a small 1.5 millimeter K wire, make a drill hole at the lateral edge of the bicipital groove, which is the strongest bone available there, because the needle cannot perforate that. So you need to make a hole with the K wire there. Then through that hole, you just pass the 5 number T-bone, and the posterior bone is a little bit weak, that you can just take the needle you can take. Now then you retrieve the needle from underneath the deltoid, and then we have a long thread of the ethibond that is going through the horizontal tunnel, and then you can use the suture technique which I just described. You can just pass the suture with simple myo needle. You just pass those suture through the ethibond and pull it off. It's really not a tunnel, it's just a small suture passage hole.
Okay. Same thing you do to take bite in a bone part of GT also, rotator cuff also.
If at all you want to do a vertical tunnel, yes, same way.
Okay. And how you take bite in the rotator cuff?
I use all different kind of these things. Sometimes I would just use a mayo needle. Sometimes I use the anti-grade suture passer, such as the first pass device, or sometimes I would use the retrograde suture passer, such as the hooks and the bird beaks and all. So we have to use all the instruments that are available with you, depending upon this. So it's especially so in lamellated tears, because and there are many, again I said, many people they'll tell you that how difficult a lamellated tear repair can be is because the retraction pattern of these two lamella are different. One lamella is retracted more, the another lamina is retracted less. Now if you want to take a bite having the two lamina in one go, then we are putting a differential traction on this, on the two lamella. So here we can just take separately through each lamella, just pull one lamella to see where it is coming. You can take to that lamina again, pull the another lamina, pass the suture to the other lamina. So with for lamellated tear, it is extremely advantageous situation.
Thank you, Dr. Pradip.
Thank you.
I have one question, Dr. Ashutosh. I have one small question.
Yeah, Dr. Neeraj.
Yeah, from where did you get this subacromial spreader? Because that's a new instrument which I have never seen. So
No,
where it is available?
No, this is an age-old instrument. Actually, it's not a new instrument. I actually got it from the States, but they are, I think, Indian manufacturer also make it. I have seen it on one of the South-based companies. I don't want to take name. You know them very well. So on their trolleys, I have seen it during conferences.
Okay, thank you.
Dr. Rajkumar, you want? Dr. Rajkumar,
yeah. Thank you, Ashutosh, for inviting me for this wonderful meeting. Sorry I joined late because I was in another meeting. I must congratulate Nemade for your wonderful presentation. Though I think your videos are running long and sometimes there was a break in the voice, but it was a very clear message that still open cuff repair can be an option or is an option to manage cuff tear. It should not be only arthroscopic. Point very well and very strongly taken here. Having said that, I have got two questions for you. You said your acromial decompression or subacromial decompression or addressing the acromion is a clinical decision.
No, AC joint.
AC joint, correct. Yeah. It is a clinical decision.
Yeah.
Correct.
Yeah.
What is that clinical decision? On what basis you will decide how you will address the acromion? Number one.
Yeah.
Number two, I must appreciate that you do preserve the bursa. Now, do you have cases wherein you may have to take away the bursa and you have done the cuff repair? And then is there an MRI to say that, these have done well, these have not done well, and clinically these have done well, these have not done well. If you have that, this will become a wonderful option for people who don't have access to do arthroscopy. That is my take on what you have done.
So I will address the second question first, regarding the bursa. So it's not a pre-operative decision per se. I think if the bursa, if I have opened, if it is not thickened and it's not inflamed like that kind of thing, then I would like to preserve the bursa. Many of the times the bursa is very thick and inflamed. So in that case, sometimes even it is almost adherent to the underlying cuff. So in that cases, identifying cuff morphology also can become difficult. In those cases, I would better off with taking off the bursa rather than splitting and pushing it posteriorly. However, if a thin bursa is there, and nice, normal looking bursa or kind of a bursa where you think that it's not an inflamed or a kind of a fibrotic kind of bursa. So in that case, I would like to just split and push it posteriorly with a gauze piece, and then at the end of the procedure, I would just repair it. That is regarding the bursa. I don't have the comparative thing that bursa has been taken off and it has been repaired and now these are done well. Here bursa has been taken off. No, I don't have that. Of course, my numbers are not that big again, this thing, but we know that a lot of bursal and bursal is being spoken about the bursal preservation on international conferences and how bursal preservation is providing much more vascularity for the cuff repair. So that again, it appeals to your logic. So that is again one of the reasons by which I would like to preserve the bursa if it is not problematic. Regarding the AC joint, now AC joint needs to be addressed for two reasons. Number one, the AC joint pain, and the second reason that it can be addressed is because whether the AC joint, under surface of the AC joint is causing impingement or not. Okay, so AC joint pain can be very well been addressed preoperatively by AC joint palpation, cross-body extraction test. Whether you think that this AC joint is troubling the patient and we need to excise the distal part of the AC joint, then you can just either you can add an arthroscopic procedure to that, or you can just convert it to take the incision much more anteriorly, much more proximally and do it, or you can convert it, you can take right from the beginning of Maximini approach and do a Mumford, and then you can do the cuff repair. That is regarding. Second, this thing is the whether the undersurface of the AC joint, the osteophytes, are causing the impingement of the cuff. So there is a very well procedure called as a clavicular AC joint coplaning, wherein we just take off the undersurface of the acromion. We don't do proper Mumford procedure. We'll just take off the undersurface of the acromion and the clavicular level of AC joint and do a coplaning of the AC joint. So this procedure can very well be done through the same incision. We don't even need to increase the incision. We can just take a small hook rod kind of thing, take off the deltoid, and we can really access very well the AC joint, and we can just nibble off and then rasp that area. If you want, you can use a high-speed burr also, and that same clavicular AC joint coplaning can be accessed to the same coracoacromial approach which I have shown earlier.
Thank you, Pradip. Thank you very much.
Thank you, Dr. Pradip. Now we are out of time. Then should we wind up? Dr. Anup, sir. Thank you all the speakers for the great show. Now I request Dr. Rakesh Singh, UA President, to give a vote of thanks.
Yeah, thank you, Ashutosh. Am I audible?
Yeah, you are audible.
Yeah, so VOA again, thanks all the participants for attending this session of the Friday musings on shoulder arthroplasty, dislocations, and calf repair. I must congratulate Dr. Dhananjay Gupta, Dr. Rajiv Gupta, and Dr. Pradip Nemade for their excellent presentations on Bankart versus Latarjet and mini open calf repairs. I thank our panelists, Dr. Swarup, Dr. Prasoon, Shamshery, and Dr. Imran. And we thank our President, UPOA, Dr. Sanjay Dhawan, our Secretary, Dr. Anup Agrawal, and Dr. Ashutosh for their august presence. All appreciations for our young moderators, Dr. Ashutosh, Agrawal, and Dr. Vinay panday for having taken in all the pain for organizing this webcast. Yeah, thank you all for the participation.
Thank you, everyone. Thank you.
Thank you, everyone. Thank you, boss.
Thank you, everyone. Thank you very much.